But I want to go back to the questionnaires, I think why do we want them to be valid? We want them to be valid because they're measuring what we think they're measuring. In this case, the impact of OA on the patients, and that's really important. So let's just talk a little bit more about the questionnaires that are available. Who would like to give us the questionnaires they use? Because
probably for me, one that I use a lot is the Canine Brief Pain Index. That's
okay, so the so-called CVPI,
yep.
Canine Brief Pain Inventory.
Yeah, inventory, sorry.
Okay.
From the cat side, the Feline Musculoskeletal Pain Index, and we've used the client-specific outcome measures. And those, I think, are one of the interesting things about validating any of these is that they're valid for what they were developed for, and in the method they were developed for. So they're on paper, then they're validated on paper. Now you've done it to a cloud-based system, now you have to revalidate. Is the same questionnaire the same for a medication that's given daily? So we proved efficacy when it's, when it's a daily medication. Now we're giving something that you only give once a month. Is the same questionnaire going to do it? And those are all things we still need to understand more about. But I think that those are the tools that we have, and we're refining them going forward.
The CVPP was used for the recent approval. The FDA has not gravitated away from the force plate. I'm sure they'll still utilize that data. But with osteoarthritis, because it's often a bilateral problem instead of one knee, it is has been used successfully to approve a recent pain drug in the veterinary market, and I think that's a direction that will be going as well.
Yeah, and that makes sense because they're saying we want owners to be able to see the difference, and so they've asked those owner questionnaires to be used. And then there's also the Liverpool Osteoarthritis in Dogs Index, the so-called LOAD. I think an important thing to mention is all of these have been produced in order to be used in practice, and so I think that's a really important thing to remember. As those instruments are out there, we can put a number on the disability, so that's I think an important step forward.
But I mean, I think we have to accept that we're also trying to look at an affective state, which is a very private and personal thing. And exactly as Margaret brought up, which was really important at the beginning, was that but we're one step removed because our patients are I say non-lingual. They do have language. It's just not a language that they can communicate with us. So we have to understand what they're trying to tell us, but we are trying to get an insight into their affective state, and that's difficult in humans sometimes that are even self-reporting. But again, when you're talking about the crossover between veterinary assessments and human assessments, there's a huge population out there in the human world that are non-communicative, like the Alzheimer's patients that have these diseases but can't communicate. So that's a huge area, I think, where there could be great matchup of research into affective states of older humans who can't communicate and our patients who can't communicate.
Yeah, and I think that the incorporation of those health-related quality of life questionnaires and issues is really important, because that's, if you look at what owners report as contributing to their pet's quality of life, they're not all the things that we ask about on these questionnaires, like how well they go up and down the stairs. They're also eating, comfort, sitting in the sunbeam. So those things that are important to owners as well, and we don't capture those in our questionnaires that are strictly really about mobility.
Duncan, I would point out this requires a real sea change here in veterinary medicine. We are quite used to getting the image and pulling the lab work and submitting that, getting a report back from the radiologist. I don't even look at them anymore. I'm not saying that we don't look at x-rays anymore, but it's getting to the point that we are relying on that kind of data. This is really up close personal stuff. It's kind of going back to the roots of veterinary medicine a little bit. And yet the same problem exists in humans. If you go to your primary care, you're not going to get the Womack scale put on you, but if you go to a rheumatologist, they'll do it. Right. So we have to circle back and change how we think about getting this information, using these questionnaires and the activity monitors perhaps on a more regular basis, that it becomes for these pets, these particular patients, these at-risk patients or patients you get a whiff that there's a problem early on, that it becomes as regular and routine as lab work and as radiographs and ultrasound. We're not there. We're a long way from it, as a matter of fact, and I hope this conversation will help maybe propel that forward a little bit.